Welcome everyone to today's webinar. I'm Emily Rapley with Becker's Hospital Review. We will begin today's webinar with a presentation and we'll have time at the end of the hour for a question and answer session. You can submit any questions you have throughout the webinar by typing them into your control panel in the space labeled Enter a Question for Staff and clicking Send. We look forward to hearing your questions. Today's session is being recorded and will be available after the event. In about a week following the webinar, we will be sending all registrants a copy of the presentation to the email you used to register. At this time, it is now my pleasure to start today's webinar by introducing our presenters. Michael Brown is the Vice President of Managed Services for Cardinal Health. Michael's 30-year healthcare industry career includes helping hospitals and health systems meet strategic priorities by leveraging the pharmacy's impact across the organization. An expert on the many facets of cost control that the pharmacy represents, Michael also has extensive insight and expertise on drug utilization management and compliance monitoring. As Vice President of Managed Services for Cardinal Health, Michael is responsible for inpatient and outpatient pharmacy operations and performance at over 200 hospitals and health systems of every size and type across the nation. He is a member of the American Society of Health System Pharmacists and a published author. Michael is joined today by Randy Davis. Randy Davis is President and CEO of NorthCrest Health. Randy joined NorthCrest Medical Center in February 2009. He began his healthcare career in 1995 as a surgical technician at the University of Alabama Birmingham Hospital. After graduating from Vanderbilt University in 2003, he joined Community Health Systems as a business analyst. He spent 5 years with CHS, and then he moved into international consulting with Bearing Point, which is now Deloitte. He's worked with and in numerous hospitals and healthcare systems, ranging from critical access hospitals in Texas and California to a multi-facility Canadian health region. Randy grew up working on cattle ranches in Missouri and Tennessee, although the majority of his childhood was spent in the Nashville area. He completed his undergraduate education at Vanderbilt University and has an MBA from Lipscomb University. Randy and his wife, Beck, have a daughter and son, Kate and Caitlin, 16 and 18 respectively. At this time, I am pleased to turn the floor over to Michael to begin today's presentation.
Thank you, Emily. And first of all, I'd like to welcome everyone who's dialed in to this website. I appreciate the time you're putting in to listen to our little talk. What I want to do first is go over some discussion highlights. I'd like each of you, person in our audience, to consider these questions as they go through the webinar. The first one, why are pharmacies underutilized by hospital leadership? What are the missing opportunities that can result in underutilizing the pharmacy? How NorthCrest Health achieved its strategic goals by leveraging its pharmacy, and what are the best practice approaches for engaging a pharmacy at your hospital? Next slide, please. I want to give a little overview of our industry's trends to just kind of set a backdrop of what we're looking at and some of the challenges we have today. So next slide, please. Hospital performance can be a moving target. This is caused by multiple factors, regulatory pressures, reimbursement challenges, the transition of care. What we're seeing today is we have more acute patients in the hospital setting, and our traditional lines of services are moving out to an ambulatory care setting. The thing that is not really changing is, to be successful, our administrators must be innovative and really consider new ideas to address these challenges. Next slide. Despite this need for innovation, most of the administrators I talk to only have time to focus on managing performance at a high level. This is a top line, it's a P&L, et cetera. In fact, Cardinal Health has done a study recently that 58% of all the administrators that we've spoken to state they don't have the time for new initiatives or innovative ideas. And when it comes to pharmacy, which I'm very familiar with, 50% of all the new initiatives are reactive, meaning that something in the external market is a factor to make those changes. So with all of this, you have to sit there and think, well, how do we address this? How can we go about being successful as administrators? So today I'm going to turn this over to Randy Davis to tell you how NorthCrest Health has been able to be proactive in developing and executing innovative ideas and how they have used pharmacy and how pharmacy has helped support hospital-wide strategic initiatives. So with that, welcome, Randy, and I'll turn it over to you.
Well, thank you, Mike, and thanks for the opportunity to be able to tell our NorthCrest story and the wonderful partnership we have with Cardinal. So we can go into the next slide. This slide just tells a little bit about us. As mentioned, I'm the CEO of NorthCrest Medical Center. Our brand is NorthCrest Health, so that's everything that we try and do under that. We're located in Springfield, Tennessee, which is about 25 miles due north of Nashville. We're a 109-bed acute care, not-for-profit hospital. We're fully independent, which I know is becoming more and more rare these days. We serve patients across upper middle Tennessee and southern Kentucky. We are formally affiliated with Vanderbilt University via the Vanderbilt Health Affiliate Network, which is comprised of about 9 other hospitals and healthcare systems. We're certified by the Joint Commission as a primary stroke center and chest pain center, along with having our PCI capabilities. Most recently, we have been recognized by the Tennessee Hospital Association for reducing overall use of opioids in our emergency department. I hate to say we are a state and a community that is on the forefront of the opioid epidemic, but we are, and as such, this is a key initiative for us as a community provider going forward. Can I go to the next slide, please? So within NorthCrest Health, we have numerous key priorities. One is what was mentioned previously. It is shifting our focus from an inpatient focus to an outpatient focus, trying to get outside of the walls of the hospital. So we want and we need to meet people where they live, work, and play every day. We're also trying to become a partner. Becoming a partner in regards to wellness and prevention, we want to be seen as a trusted advisor to patients in the community. Another priority is to better develop and maintain key strategic partnerships which augment our mission and vision. We don't want to be just a referral source, though, for the larger entities in Nashville, which has been a strategy in the past. We want and must add our own value to our own community. And finally, Mike, as everybody mentions, you still have to achieve a margin and to do all these things. But speaking about pharmacy, though, pharmacy plays a role in all these priorities. The community education and our partnerships and affiliations are a key driver. When we start getting outside of the walls of our own facility, though, fully embracing the demands associated with consumerism, we really have to understand our customer, our patients. They really want convenience. Most people want to get a test when they want it, where they want it, and they expect everyone to have all their information at their fingertips. And so with us to partner with this community, we want to be the source of truth when it comes to healthcare, but they must trust us. And it can't be a gimmick. We can't be trying to drive this trust to drive volume or increase short-term revenues. We have to be open, honest, transparent. We have to use a concierge model to help community members navigate what is a very complex and incredibly misunderstood system. Pharmacy plays a huge role in that. The pharmacist being able to work with the patients at time of discharge, working with the primary care physicians, helping patients understand what meds they're on currently versus changes we had to make in the inpatient space, how that impacts how they take their medications after discharge. All of these things require full pharmacy support. And I don't mean full pharmacy support by a pharmacist sitting on a computer in a back room accurately entering medication orders. Of course, that's vitally important, but I mean actively working with the patient to help them truly understand their medication management. So strategic partnerships, working with Vanderbilt, looking at their evidence-based practices, seeing how and when medications should be ordered, working with the primary care physicians. Our pharmacists are sitting at our right hand, playing an instrumental role to ensure that good information is going out internally and that we work well within our network. So can I go to the next slide? So I find this to be a very interesting slide because I'm sure many of you that are on the call today are thinking, should I just make or should I buy my own solution? In other words, should I pay someone to deliver the service or can I just handle it in-house? And I think we all understand on-site pharmacy staff have the demands on them of accurate order entry, working with the quality team, the day in, day out of the job they have to do for clinical initiatives, providing nursing and provider education, and as I previously mentioned, sitting down physically with all of our inpatients prior to or right at the time of discharge And sometimes they're having to sit down with these patients numerous times during the day. So if you're thinking about that, this is a ton of time and effort. And still, like I said, all the orders have to be verified. We can't dispense meds out of the automated dispensing cabinet until a pharmacist has reviewed the order. Basically, the normal day-to-day demands of the pharmacy, but more and more effort is being placed on the front end in regards to working with the patients. So this isn't always the easiest thing to do in terms of building this program yourself and delivering it in a meaningful way through a standard employment model. Next slide. So that is why we really consider pharmacy services as our partner, not trying to do it ourselves. We understand when you bring this bigger entity in, which solely focuses on the pharmacy aspects of our business, that not only do you get the person on the ground with you, but what you're also getting is this broad-based organization behind them, backing them up with evidence-based practice that can explain so they can explain that to our providers. And by the way, providers both in the community and those that are working inside the hospital. The different challenges associated with pharmacy, such as medication shortages, those are huge. And having that expert explain to everyone involved what that means, how to work within the confines of those shortages, working with the different formularies, even if it comes to, well, we're a fully insured insurance plan, which we have for our employees. And we had the pharmacists even work with us internally to better understand our pharmacy benefit manager, working with our HR director to fully understand what the medications are that our employees are taking, and trying to understand that particular medication, the expense. I mean, it's a significant cost within our insurance plan. And so that pharmacy partner is working with us on all facets of that within our organization. So that's what Cardinal is able to do for us. They're able to come in, keep us abreast of everything, and I'm talking from new legislation to new policies, changes in protocols which are coming down the pipe, making sure that we're proactively addressing these things within our own policies and protocols, working with our P&T committee to get those changes communicated out and make sure that everyone's educated up on them. But they're also sitting with us on the outpatient side. They work with us on how we can raise the bar of quality, since again, what I'd mentioned is a significant amount of our patient care is being delivered more and more on the outside of the walls of the hospital. So making sure that the patients and the clinicians are fully up to speed. They're able to work with us on all of our strategic initiatives. So definitely they are generating cost savings in terms of our medication usage, but I'm not just talking about our inpatient formulary medication usage. I really do mean even our own pharmacy spend on our own insurance plan. I think if you want to look at outcomes, the quality is pretty transparent these days. So if you want to know about that, you can go out and look at us. We're an open book, just like everyone else, I'm sure, that's on the call. But I think that our outcomes speak for themselves. So everybody's just doing a really good job. But with the other type of reporting that they bring to us, we are able to have a quarterly business review, which we sit down with. We look at our trends around high-cost medications. We ensure we really are doing the best for the patient, as well as meeting the needs of our clinicians. Primarily, I would say if you polled our medical staff, they would tell you our on-site pharmacy director, as well as the support that the director receives from Cardinal, it really does allow them to feel confident with the decisions they make concerning medications. And this extends out to even the confidence that our primary care physicians have in the outside community. Next slide, please. So here's what I was talking about in regards to our major priority. And again, how to become a trusted advisor to patients is huge. You only get an opportunity to be trusted one time. If you abuse that trust or in any way violate that trust, it's gone forever. We have been able to work very closely with our emergency department, primarily around the opioid issue and raising awareness about the opioid problems in our community. But what this has also allowed us to do is start using our ER as a beachhead. We've been able to go out, and I say we, but it's really our pharmacy director and Cardinal, but I'll take the we. We've been able to go out and meet with the local paramedics, all the different services around town, like the local health centers, and just educate all these providers, get education in the hands of patients, specifically around expectations involving opioids and the alternative to opioids. And this has been a key driver that Cardinal's been able to help support as we've gone out into the community with it. In talking about the concierge model, we are attempting to ensure every patient who comes through the door gets that one-on-one attention and one-on-one care. Our pharmacy and Cardinal have made the commitment that 100% of our inpatients who come through our facility, and I included observation patients in that inpatient category, the patients will have an actual pharmacist sit down with them, fully educate them about the medications they were on when they came into the hospital, fully educate them on the medications prescribed and if those medications were changed during their inpatient stay, but then explain the medication changes and why when they're looking over their prescriptions at their time of discharge. So additionally, they let them know what they should be discussing with their primary care physician. And this is fundamental. It's fundamental to successfully transition a patient from the hospital-based medications back to the outpatient world on their own. That hand-holding, that sitting on the side of the patient's bed, looking in the patient's eyes or the person who'll be responsible for their care at home, and making sure that good understanding exists. This is absolutely key to a concierge model. And I'm happy that our pharmacy has agreed to work with us and support us in that initiative. Also, they've been providing that service for 4 or 5 years now, so it wasn't just a flash in the pan or some fly-by-night initiative. It's become ingrained in how we provide care to all of our inpatients. And so finally, rural hospitals and the clinical quality outcome support. This is really an interesting story, or at least I feel it is. There are 2 small critical access hospitals near us, which were struggling financially to the point they were talking closure. And in our true not-for-profit community way, we wanted to extend our help and our services out to those hospitals and see if we could help them remain financially viable, remain open, and remain that source of quality care to their community. To let you know, this is not self-serving in any way. These hospitals are so far outside of our market that they actually can't even send us patients. So this was not a business decision trying to increase patient volume. Frankly, from a business decision, it was not smart. But regardless, we went out there, and when we did, Cardinal was right with us. Their pharmacy director came out with us to those facilities, implemented the exact same policies, protocols, and initiatives that we had, provided the same support they provide to us, and they treated those hospitals just like us. They basically said, wherever you go, we go. Meaning if you go out there and help them, we're going to go out there and help them with you. So, by the way, that was our only partner that said, yes, let's go out and help these hospitals. But I must say, not only did they offer the same level of service, they significantly increased the level of quality of these facilities. Houston County Community Hospital was one of these 2, and actually when we came in, they essentially had a non-functioning clinical or inpatient pharmacy. But now when the Joint Commission came in for their accreditation survey, they received 0 medication management findings. So I would say that having a willing partner to go out there and help, first of all, was amazing. But to go out there and help in such a world-class manner that essentially earned them accolades from the Joint Commission, that was great. And I couldn't ask for anything more. See, the last really is the cost savings. The antimicrobial and opioid stewardship program, these 2 really trying to take them into these rural communities, which, by the way, are even more rural than us. What we see is the opioid crisis and antimicrobial stewardship. These small facilities simply don't have the resources to be able to deploy the education and devote the resources. But through the partnership, Cardinal was able to come right in with us arm in arm. They put the same level of energy and resource to these facilities as with us. They put the antibiograms together, got that into the hands of the community providers, letting them know, this is the antibiotic that works the best in this community. This is the one that doesn't. And so it was refreshing. And it was great to be able to see that Cardinal not only helps us, the 109-bed hospital, which is essentially located in a suburb of Nashville, but they were willing to go all the way out to this small, extremely rural critical access hospital. And it was just a great opportunity and I appreciate that partnership. Next slide, please. Okay, so second priority, that's maintaining key strategic partnerships. And in large part, this is primarily our affiliation with Vanderbilt. It's nice to be partnered with a large academic medical center, but sometimes it's very daunting to be partnered with a large academic medical center. So Cardinal, through all their resources, have been able to be able to serve as a bit of an intermediary between us. They've been able to take the Vanderbilt clinical programs, help us evaluate them and say, this will or this won't work in a community hospital. Here are some changes we need, or these can work, but they need to be implemented in this particular way. So we have to remind all parties, things that work in an urban academic medical center may simply just not be feasible in a community hospital with different services and resources. But it requires some very smart people to evaluate what translates, how does it translate, how can we benefit. The other is, because of the affiliation, our PBM sits within the affiliated network, and our Cardinal Pharmacy Director has been able to sit down with the administrative team and our HR Director and do a deep dive into our own employees, see how they're being treated by our primary care physicians, and how the employees are actually utilizing their medications. Is it for its intended purpose or something else? The prescribing pattern of our physicians, and how can we educate everyone, and ultimately, how can we reduce that spend, which of course saves us money, but ultimately it results in reduced premiums and lower cost of insurance for the employees in subsequent years. And these results have been very impressive. Finally, we are a member of the Tennessee Hospital Association. Being a member of THA, the membership as a whole is pretty elevated. It's filled with, of course, CEOs, but the specific meetings with the committees, such as the quality committee, the data committee they have, in those you encounter managers, directors, vice presidents within systems and facilities, both large and small, who are incredibly dedicated, incredibly intelligent, and fully energized to tackle big tasks. And through this involvement, we're able to tackle things at a high level. We're able to work with state legislators and drive change within a community. Cardinal's been right there with us even in these collaboratives. They help us pursue grant opportunities, but it broadens us. It allows us to not just be an independent hospital sitting alone on a hill. Tennessee Hospital Association allows us to function as a hospital that's sort of within a system, have that ability to network and grow, develop ideas, and raise the bar for a hospital in Springfield, Tennessee, higher than what you might typically expect of a hospital of our size and location. Next slide, please. So you may be listening to me drone on and say, well, this is a great story, but what can you measure? If you go out there and look at us, you will see patient satisfaction can be a struggle for us at times. But if you look at our scores surrounding medication and medication management, you'll see we perform very, very well. I think if we could find a way to make our hospital a little bit less noisy, since apparently we're the noisiest hospital in Tennessee, we would be significantly higher than the 75th percentile. By and large, though, our high HCAP scores result via the concierge model in which Cardinal plays a huge role. That one-on-one education of every inpatient is a significant driver of this, and because of this, we do score as a 4-star CMS hospital for patient satisfaction. And also, while I mentioned that Houston County had no medication management findings by the Joint Commission, I can also say that neither did we. In the most recent survey. So clearly, Cardinal is able to reproduce these efforts regardless of the size of the facility. Another thing that I failed to mention when I talked about efforts to reduce opioids, our Cardinal Pharmacy Director is a leader within the Tennessee Hospital Association group that's focusing on reduction of opioid use in the emergency department. We benefit directly, of course, from his work, but he's making an impact statewide as well. And so I just, having the opportunity now, would like to publicly thank Cardinal for allowing him and supporting him to work with the entire state of Tennessee to drive down the use of opioids. And I just can't thank you enough for that. Next slide, please. Okay, so you may be thinking how we can use pharmacy to be the center of innovation for your own hospital. I think there's two big takeaways. The very first is this culture of innovation. You can't be afraid of failure. You really have to have a fail-fast mentality. You have to get in there and start driving some changes, make some changes, but be open, honest, and transparent. I do think that is what we have here with our pharmacy staff. They sit at the table with us and help think of different ways we can make changes. Now, we are fully independent, so we don't have to go up through a corporate office and have these ideas or plans blessed before we can implement them. So we are able to be pretty nimble. But ultimately, though, you have to be willing to make change as long as you're making sure that quality is paramount and it's in alignment with any cost-cutting strategy that you may have if that's a driver in there. So again, that's like I said, it's paramount. If the dollars start coming before the care, then you can't drive innovation. You will lose the team. But if aligned appropriately, it definitely works. And so you can really drive this culture of innovation if you allow people to take some chances. But you have to make sure it's interdisciplinary. You must have everyone at the table. So we formed our teams to tackle initiatives. And to be honest, the very first thing we did was we removed all the managers, directors, and vice presidents from the room. We put people on the team who actually do work every day. We made sure to cover all facets of care. It is pharmacists involved, but it's also the rad tech. It's the floor nurse. Sometimes it's the unit clerk, depending on what you're trying to do. It's these people who actually understand your problems. And it's these people who, when empowered, have the best solutions. And because it generates so much buy-in, there's frequently a lot of energy to these solutions. So by putting these teams together, we've been able to tackle all of our key initiatives. And we'll spin up one of these teams just about any time we have an issue that we need to address. And I can tell you that in these teams, we probably overuse our pharmacy team in this approach. But when you're attempting to drive communication and drive that concierge model, they have to be involved. And they're very well respected within the multidisciplinary groups. So we pull them into everything that we can do. So with that, I believe I'll turn it back over to Mike.
Thank you. Before we get to the broader questions and discussions, I do have a couple questions myself, Randy, if you don't mind. You just got done talking about how you really are incorporating pharmacy into your strategic plans, et cetera, but what were the initial steps you took to get them involved in the strategic plan?
Sure. This is kind of like a truth moment, or a circle of truth. Can we talk open and honestly? Right. So the first thing we had to do from an operations standpoint was understand the pharmacy played a role. I've been in a lot of hospitals and on a lot of operations teams, and when I saw the pharmacy director, typically I saw them simply going in and out of the CFO's office. So since, again, I was on the operations side, I was looking at the pharmacy just like you would a supply department. And I figured they're working with the CFO, they're trying to drive down costs, that's what they do, and that's all they do. So it was stepping back and realizing we had done some value stream mapping in the past, and we saw how many touch points that there could be with pharmacy if we allowed it. So we had to make that decision and just say, you know what, yes, it is important to have the rapid turnaround time on orders. It's important to find those cost-saving opportunities. All those are important. But it's also important for the educational component for the patient and the staff and the doctors. So the best expert about medications is the pharmacist. And so when we started looking at readmissions and recognizing that a large cause of our readmissions was simply a misunderstanding by the patient or the primary care physician, and these were happening in the transition of the patient from the inpatient world to the outpatient world, it only made sense to involve the pharmacy in that. And by the way, when we were polling the primary care physicians in the community, this is interesting, they were upset with us. They were upset because they also didn't understand the medication changes that we were doing inside the hospital, and they felt that we were making them look bad to the patients because of the medication changes that we were making. And so the pharmacists were able to go out and have those conversations and educate those community docs as to exactly why we were making those changes. And sometimes it was just simply due to the formulary that we're on here, or there was some outside factor that was specific to that acute care visit. And so it was a very, very strong liaison work that the pharmacist was able to take on. And so as we stepped back and looked at all of our initiatives, we quickly saw that the pharmacy could play a key role if we would allow them, give them a seat at the table and let them participate. So once we did this, we were met with great success. So in a nutshell, I would say that the steps we took were internal. They were removing our own inhibitions of not involving the pharmacy.
Great, thank you for that. We've been partners for quite a while now. Can you think back, what are some of the criteria that went into selecting a pharmacy partner?
Well, yeah, there's significant different variations. So the first is, I could say that jokingly, if anyone is trying to do this in-house and has had turnover within their pharmacy staff, and you are in the middle of trying to find a new pharmacy director, it does not take you long before you're probably throwing your hands up and going, I wish someone else would do this for me. So kind of tongue-in-cheek, but kind of for real, trying to maintain that staff and just frankly letting that be somebody else's problem. But the other is in looking at, of course, we went down the path of the cost analysis. Can I do this cheaper? Can I do this in-house myself? But when it started coming down to exactly what we were looking for, what we were attempting to accomplish, how we wanted to engage the patients and the employees, how we wanted to engage the medical staff, it became pretty clear that this was not just simply a cost analysis. This was not simply, can I hire and fill slots in a department at a reduced cost or at the same cost as what a Cardinal could or a partner could. This is, I need something bigger with broader depth and breadth than what I can achieve just within my own group. And so I would say that the factors were all the above. We did look at price. We did look at our ability to consistently staff a department and keep it up and running. But the other was, how do we keep them on the cutting edge, the forefront? How do we make sure these people are invested in and can be tied into a network? And so Tennessee Hospital Association is great, and they provide that. But when you're talking pharmacy specific and trying to make sure that we've got those resources, it was overwhelming that we needed to look at that. And so I think that with all those components factored in, that was what we were going through in terms of looking for that strategic partner. And while we settled with, settle bad word, but while we excitedly chose Cardinal to partner with.
Well, good, thank you. Knowing that you've selected a partner and going through the process, do you have any advice or lessons learned that you would share with a fellow administrator who's thinking about doing something like this?
Sure. The first is, don't just look at an invoice cost. And I mean, don't just look at, don't pull that service line and go, well, this is how much it costs me to do it, and then this is how much it's going to cost for someone else to do it. You've got to look at your program as a whole. You need to make a decision right now. Do you believe in a clinical pharmacy program? Yes or no? If you just want someone to accurately enter orders in a computer and make sure that they're rapidly verified so that those nurses can dispense those meds, then that's one thing. And by the way, I'm sure y'all can do that and would do a great job at it. But I think that you need to look at a strategic partnership and how you can raise the bar in terms of the care that you're giving. And so I think it's that. It's take that introspective look. It's look at all your processes, look at all the problems that you're trying to tackle, and envision having pharmacy at the table with those. And again, not just a pharmacist, but someone who's supported by a very large organization. And then you have that internal dialogue of, do you think they can bring some additional resource that you can't have beyond yourself? And I think the answer will be yes, but I would encourage everyone to go through that thought process.
Okay, great. You ready for some questions?
Sure, let's have some questions.
Emily, we're going to throw it back to you to open it up for outside questions from the audience.
Thank you so much, Mike and Randy. That was a fantastic presentation. So we will now begin our question and answer session. As a quick reminder to our audience, you can submit any questions you have by typing them into your control panel in the space labeled Enter a Question for Staff and clicking Send. And we'll try to get through as many questions as we can today. So it looks like we got a lot of great questions already coming in. Our first question from an audience member is, did the hospitals make use of Cardinal Health's remote order services? And if so, did that help with providing frontline pharmacy one-on-one patient services?
Yes, that was actually one of our early initiatives that we did. We had identified that we wanted to go to full profiled machines. We wanted to reduce, if possible, all overrides. And so that was the key driver, to go to the remote system, use that for our nighttime coverage. And I would say easy turn on, easy to use. I hate to say, almost became a non-issue. I mean, it just rolled in seamlessly. So I'd say that we had very, very good experience with that. And yes, that's what we used.
Excellent. Thank you for clarifying that. The next one is about critical access hospitals. So we have an audience member who asks, would Cardinal programs be cost effective even in a critical access hospital with less than 10 beds?
I think I could handle that. When I said yes, they would, and the way we do some of our agreements, we work with that clinical access hospital on exactly what they want. So we have quite a few that we work with today. I'm not going to get as specific as our terms of an agreement, but yeah, absolutely. There's opportunity there, and they can cost justify it. So.
Perfect. Thank you so much for clarifying that. So this next question is about getting support from leadership. So we have an audience member who says it's great to have support from the president and CEO. Randy, was this initially driven from the top, or was it driven from the pharmacy department making a case for developing clinical pharmacy services?
It's tough to answer because now I'm thinking back. It has been it's been a while because we have been partners for a while. It's a little bit of the chicken or the egg. I'm trying to think back and say exactly. It was not a top level at the time. I was a vice president, and we didn't sit down in an administrative strategy session and go, we need to grab pharmacy and pull them into this. I think it was more of a realization. We had formed the CUSP team, so we use a CUSP model, the CUSP, the Comprehensive Unit-Based Safety Program teams. We had dovetailed that into some lean efforts that we were doing, and with lean, you get the rapid improvement teams. And that was when we realized that we had to have the multidisciplinary approach to be able to attack problems. We started looking at these processes and mapping them out. We started saying who's involved, who's not involved. And I think it was just that. We noticed that the pharmacy was playing a role in all of them, but then we looked around the room and there was no pharmacist in the room, and that was because we never invited them. But as soon as we made the offer and extended it, our pharmacy director gladly joined in. And so it kind of evolved from that.
I'm going to add on to that because it's interesting when you look at the evolution of it. I do think it's kind of a chicken before the egg, but where it's at today, before the seminar, Randy and I were having a discussion about a new service line that they're going to add here at the hospital. And we were talking about, okay, well, here's what we can do for you. And we can hook you up from a pharmaceutical perspective. And we were talking about what kind of impact that's going to have from a financial, from a clinical, et cetera, because it's a different service they don't have today. And it's just, we're part of the team and having those discussions before the new unit even opens up. So the evolution is it's hard to go back and think how it started because we're just so used to it now.
Right.
Absolutely. That makes a lot of sense. So it sounds like you invited those pharmacy leaders to the table.
Fair to say.
So what could a pharmacy leader do to get their administrators to view them more as strategic partners?
Sure. I think if you think about a pharmacy leader, first thing I would suggest any pharmacy leader on how do you get invited to the table, you really need to understand what are the objectives or what are the strategies of the facility itself. And once you understand that, you can start looking into pharmacy, and really it's easy to identify areas that you can leverage, your knowledge, your skills. Here's where I'll be involved, and here's how I can help. And then take it to the administrator. There's very few administrators that told us that, no, we don't want your help. They're just not aware of it. And that's where it really is important that you have a strong leader in the pharmacy that's really promoting pharmacy and what you can do. I always tell people this: I don't care what setting you're at in a health system today, whether it's in the hospital, whether it's in a clinic, whether it's in an infusion center, there's medications there. And if there's medication there, pharmacy can help them, and they can help them with the strategies that they're trying to achieve. But it's back to
Absolutely.
Right. All about knowing what the hospital wants to do and where they want to go.
That makes a lot of sense. Thank you so much for clarifying that. So we have another audience question who says, we are struggling to have a pharmacist meet with each patient at admit and discharge due not to pharmacy desire, but competing tasks and limited hours for the pharmacist. How do you staff your pharmacy and create enough time to enable your pharmacist to do this? I think, Randy, that's a question for you.
Yeah, I can answer that. The way we do that model, we do have a pharmacist meet with them. However, a lot of the background information, which is really time consuming, that's done by a key tech. And when we were wanted to implement that program, we said, we do not have a technician or a person on staff that we felt was really good at looking at MedRec. And that means, because when we're looking at a MedRec, it's not just what they come in on. We want to know what if they're taking OTCs, anything like that. So we went out and recruited a technician from retail who's familiar with a lot of the stuff that as a traditional inpatient pharmacist or tech wouldn't really know about. So that individual does all the background for it. I think there's two of them, but they do all the background. They prep everything. So it's a very easy conversation for the pharmacist to go up and do that. They're already decentralized up into their clinical module. So when they get the notification that that patient's getting ready to go, they can go down there and talk to them, and it's all in a summary format. So we've streamlined the process. It was a process over time, and yes, you will go through struggles with hitting everybody as you kick this off, but as you live and learn it, you're gonna fine tune it, and then you're really going to become successful about it. What we're finding, and just kind of full disclosure, what we're finding is that the retail stores out there are kind of wondering what we're doing now, because we're arming our patients with a lot of information, and they have a lot of questions. And the patients are finding out they've got medications on their records in the retail stores that they're not on anymore. So we're seeing the impact, at least the feedback, and I think it's just a fantastic program here at this facility.
Excellent. Thank you so much for clarifying that. So we have another audience member who asks, do you also incorporate telepharmacy?
When you mean telepharmacy, I'm going to take it from the traditional, like remote order entry, and then we also do remote pharmacy services. So we'll do, counseling after hours, stuff like that. We don't do off-site telepharmacy where we have like little retail stores where we're filling scripts and doing patient counseling or anything like that. So that's a different type of telepharmacy. So we're not doing that here.
Okay, thank you so much for clarifying that. So our next question is about savings, hospital-wide savings goals. How does the pharmacy help achieve aggressive hospital-wide savings goals?
So primarily working with actively with the medical staff and the clinical teams. Of course, you're always doing your, the IV to PO changes, the normal type of moves there. But also in looking at the quarterly review, we sit down every 3 months. We look at high cost medications. What caused those to be used? Were they the most clinically effective for that particular patient? And just trying to drive that efficacy, but making sure that you've always got the quality piece sitting out in front. But that's a large part of what we do. But I would say that the pharmacist jumps right in with the anesthesia team and looks at their multimodal approach of anesthesia and how can this work, and can we achieve these great results, but kind of educate them going, hey, this is how much this med costs and this med costs, and if you can put this multimodal approach together with this other piece, then that'd be great. I think it gets all the way into where y'all are looking at our med gases and seeing, are we isoflurane and all these kind of things. So it's across all facets of it, but I would also say that a large portion of it, we may have a business review, and we may see that a cost has spiked because of a certain usage of this medication or this driver, but then our pharmacy director jumps in and he spearheads it going forward. So he takes it to the Department of Medicine and explains the rationale behind it and why we want to make this change, gets buy-in from the medical staff, takes that back to P&T, gets the vote, and then delivers that to our medical executive community. So, or our medical executive committee. So that's primarily, he is carrying this all the way through, but it's a strong medical staff driven approach that he has, and he has the respect of the medical staff and therefore is able to do this very effectively.
Absolutely. It's really helpful to understand kind of how those processes work at your hospital. Okay, so this is our last question today. How do you measure the value of pharmacy management services to justify the costs associated with outsourcing?
I immediately start smiling at because the day of the CEO, right, is if I can eliminate one less problem coming through my door, then that's worth its weight in gold half the time anyway. And so just having a well-run program that works with everyone else within the organization as a partner and a team member has its own value. In the business reviews, we are able to see kind of our cost of spend on medications and know that we're aggressively driving to keep those down. So there's a benefit there. Now, granted, we've been in this partnership for well over a decade. So, I mean, it's not like I can go back and go, well, last year we spent this and this year we spent that in comparison to Cardinal's performance versus prior to it. But they do compare year over year, quarter over quarter. So you're able to continue looking at your spend amount from that standpoint. As far as the resources, I mean, that's one where you can just look at, well, this is the management fee that was charged, and this is how many resources you have, and you're achieving your goals, and then you can turn back and look at how many you think you would need to do that. I would challenge it if you think you could do it with less. But I think that at least that's my mindset for going through how do I justify at the end of every quarter of it and at the budget year is this a good decision and should we continue?
Yeah, and I'll just add on to it. Like I said, I'm not going to get into contract terms, but the relationship we have with the facility is there is a guarantee financially that protects them. So if their cost will not exceed a certain amount, it's in the contract that way. So there's a sense of protection there also. But that being said, it's really upon both parties to work together to control costs, whether it be drug costs or staffing costs. So.
Thank you so much for clarifying that. And it looks like we actually have a couple last-minute questions coming in. So I'm going to go ahead and ask these as well. We have an audience member who asks, how has your board of trustees or board of directors shown support for your initiatives?
So my board of trustees pretty much, they made me put my money where my mouth is, right? So a large portion of my pay is aligned with the quality of this hospital. And in quality, I mean our patient satisfaction scores, our outcomes. So where they don't necessarily dive into the actual strategies that are deployed within the hospital, that is the CEO's role to develop those strategies. They are very concerned about our perception in the community, the outcomes in the community, our relationships with with both the patients and the physicians. So they are very supportive. They are very focused on it, and it is a very strong demand of theirs that we maintain this high bar.
Thank you. That's great to hear. So our next question is, medication reconciliation occurs throughout the transition of care. Could you speak to the pharmacist's involvement during transitions to different levels of care and upon discharge?
So we do a couple of things. One is if you're transferred to the unit, the critical care unit, they have daily rounding on them as a team. So of course you've got the physician rounding on them, but there is a multidisciplinary rounding team that literally goes bedside to bedside on those patients. And so we've talked a little bit about the medication reconciliation, and of course that occurs and is monitored by the quality team to make sure that gets done in a timely manner. But there is a little bit of a deep dive done on every single patient that went from the floor to the unit or was admitted from the ER directly to the unit. With this rounding of let's all get on the same page, let's all get our act together. The other is on the med-surg floors, they don't round at the bedside, but they have the multidisciplinary group all gets together in a single room, and they individually talk about every single patient every day. And in that, they're also talking about, they look at the medication reconciliation, make sure that we're on the right meds, we're on the right track. And that one, the physician is participating as well. And then over and above that, I think I think our pharmacy director actually still leads the morning bed meeting. And in the morning bed meeting, you kind of get the department heads together, and that's where they're talking about, do the patients have a Foley? Do they have a central line? How long's it been in? Should it come out? These kind of things. So, but in all these conversations, they are talking about patient movement throughout the hospital, and is everyone aware? Does everyone know this is what happened, why it happened, and are we appropriately aligned in the care of that patient in their new setting?
Thank you so much for clarifying that. And with that, I would like to wrap up our question and answer session. I want to thank Michael and Randy for their excellent presentation and Cardinal Health for sponsoring today's webinar. To our audience, please enjoy the rest of your day, and we look forward to having you join us for future webinars.